will invade the intestinal epithelium. So when they are released, they will be taken up by the mesenteric lymph nodes, which are easily spread to the other organs like brain, muscle, eye, or the fetus, which is a transplacental spread. Once they enter, they transfer into a either actively multiplication or they may go in for a tissue cyst formation. So the cat gets infected when they ingest the rodent meat which is going to contain this tissue cyst. Usually if it's a human tissue cyst, it will be a dead end infection. Otherwise, if it is other mammals, when the cat eats the tissue cyst containing in the mammals, they get infected. So whatever the bradyzoids are present will be released. So again, in the intestine, they multiply with the sexual method. So the bradyzoids results in male and female gametocyte formation with the gametogony process, which further releases male and female gametes. This male and female gametes will undergo fertilization, which forms a zygote. So the zygote, which is released outside in the feces of the cat, which is an unsporulated oocyst. This unsporulated oocyst in the environment within 5 days will get converted into an sporulated cyst, which has sporocyst and a sporozoites. So this can get entered again into the man or the mammals when they contaminate food or the water. So that's the overall life cycle of the parasite. Coming for the epidemiological distribution. So globally, the prevalence of this parasitic infection is around 25 to 30%. The risk factors for the infection will be usually presence of cold environment, hot, dry climatic conditions, high altitudes will usually have lower prevalence when compared to the other climatic conditions. The usual age which is affected will be the elderly individuals or the fetus whose immunization, whose immunity is usually less. So as you can see in the picture, the prevalence is so the purple colored places will have more prevalence where there is more than 60% of the prevalence, and in few areas there are 40 to 60%, and in gray areas you have 20 to 40%. In blue areas, dark blue, you have 10 to 20% and less than 10% in the light blue area. So in India, you can see some areas there is high prevalence and in some there is low prevalence also. Usually, exposure towards the cat on the cat feces is the most commonest route because they can contaminate the food and the water if you are handling them. Ingestion of even uncooked animal meat will also pose a higher risk if they are infected and they have a tissue cyst. Presence of Okay, so ingestion of any uncooked animal meat will pose a higher risk. Presence of immunocompromised condition is also one of the high risk. Usually the persons where there is organ transplantation, blood transfusion, those people will have a high risk for development of the infection. So as such, whenever the mouse is getting infected, As such, whenever the mouse gets infected, they say that they will have the ability to control over themselves, and they usually lost fear for the cat. So the mouse will go and try to hug the cat, making the mouse itself more prone for getting catched by the cat. So that's how the life cycle is maintained. Because of this, the cat is going to eat the mouse. So the parasite is going to make the mouse fearless of cats. So when they go near the cats, they are going to eat the cat, where the life cycle is going to get continued. So that's the ability of the parasite, so that in order to maintain its life cycle, it's going to do that. So next, in the life cycle, in the lumen of a small intestine, whenever the trophozoites enters, they are uptaken by the soluble materials or the parasitic debris, whatever they release. They invade the cells, usually with the help of the dendritic cells. They can travel along the lymph nodes and reach most of the organs. When they invade the macrophages, they are usually resulting in the killing of them. And when they are taken up by the neutrophils, they result in release of a lot of immunoregulatory cytokinins, which helps the killing of them and also results in lot of immunologically reactions which can happen in the body after exposure. So the Toxoplasma oocyst, once it is released in the feces of the infected cat, they undergo sporulation in the soil and they get matured. The matured oocyst will be either ingested by the sheep, goats, cattle when they are grazing, and they undergo conversion to tachyzoids, resulting in tissue cyst formation either in the muscles or in the brain. So this can be ingested by the humans when they consume undercooked or a raw meat, or else the humans can get infected when the matured oocyst is contaminated in the hands, in the food and the water. So once they infect the humans, there are three different cycles which can happen. Infections, if it is happening in an immunocompetent individual, they will be mostly asymptomatic. And if the infection happens in an immunocompromised individuals, they may develop tissue cysts which can result in various organs involvement, causing seizures, poor coordinations which can happen due to the brain involvement, or it could be infection of a pregnant human where there is development of congenital toxoplasmosis, which is one more thing. So these are the three different types of presentations which can have in a toxoplasma infection of human beings. So coming further, each one, if it's an immunocompetent individual, usually it will be asymptomatic and they will always self-limit themselves. The commonest presentations would be lymphadenopathy. Mostly the cervical lymph nodes are involved. Along with that, even suboccipital, supraclavicular and inguinal lymph nodes enlargement can happen. With that, certain other symptoms associated like headache, malaise, fatigue, and fever can happen. Other rare symptoms like maculopapular rashes, pneumonia, myocarditis, and encephalopathy can develop. If it's an immunocompromised individuals, then it usually undergo dissemination in lymphatic tissue, skeletal muscles, myocardium, retina, placenta, and CNS. All these areas can be infected, having symptoms associated along with it. If it's an HIV patient, what do you have to look for? It's one of the opportunistic parasite which can infect whenever the CD4 count goes less than 100 per microliter. There may be either direct infection or mostly it will be a reactivation of already the latent infection which was sleeping. So the commonest site would be the CNS where Toxoplasma encephalitis can develop, or even pulmonary infections or even eye infections in the form of chorioretinitis can develop. So you can see the picture. So that's the retina where the choroid plexus and the retina is involved. So active infections will look like some bleaching and you will have scarring if it's a long-standing chronic infection. If it's a CNS infection, it could be either directly invasion where there is necrotizing encephalitis development. So this results in altered mental status, seizures, sensory abnormalities, cerebellar signs, and focal neurological findings like motor defects, cranial nerve palsies, or even visual field loss can happen based on what site of the brain is involved. Okay, which part is involved, which site is involved, which cranial nerve it is pressing. Based on all these things, the Toxoplasmosis CNS infection can happen. So coming further, congenitally toxoplasmosis when it infects the pregnant woman. So if it's congenital toxoplasmosis, sorry. So the infection depends upon the gestational age. The outcome of the fetus depends on at what age it got infected. Usually they say if the gestation proceeds, the chances of transmission increases, but the severity for getting infection will decline. That means transplacentally during the first trimester, the chances of entry is around 15%, whereas the chances of entry will increase as the days increases, but the infection severity will decrease. That means if you are infected during the first trimester itself, then the chances of congenital abnormality will be more. They say 1 per 1,000 births can have infection with the congenital toxoplasmosis. So what's the classical triad when it's a congenital toxoplasmosis? Usually they present with chorioretinitis, hydrocephalus, and intracranial calcifications. As you can see in the picture, so this is the classical triad if it's a congenital toxoplasmosis. So they say that if it's a congenital toxoplasmosis, what are the outcomes you can have? So it could be a stillbirth, psychomotor disturbances, or there may be microcephaly instead of macrocephaly also. So there are a lot of findings which can happen during the time of the birth, and what could be the percentage of its presentation is also being studied. We can see prematurity can happen in around 40% of the cases. Sepsis can develop in 40%. Rash, petechiae can develop. Hepato or splenomegaly, chorioretinitis is usually around 80%, and CNS calcifications and abnormal CSF cell levels are all 80%. So these are the various presentations they can have during their birth. So this much is about the clinical features, how they present. Now we'll talk about the laboratory diagnosis of them. So usually the specimens what you take depends upon what site it is infected. So the most commonly the peripheral blood, body fluids, lymph node aspiration, bone marrow aspirations are very commonly used. Lymph node is mainly because it causes lymphadenopathy. Bone marrow is usually the macrophages. Once they get infected, they go and can deposit them there. So you can even detect in the chronic stages, bone marrow aspiration would be better. Other than that, CSF, it's brain involvement. Bile fluid can be taken if it's in HIV, where either the pulmonary or the brain is involved. And if the organs are involved, you can even take biopsies of spleen, liver, and brain. So these are the various specimens you can collect. So you can either do a staining method, or you can culture them, or you can directly see under the microscope. So to stain them, what are the various things you can use? You can use GIMSA, pass staining, or silver stains can be used. So as you can see in this picture, so the left side is the unstained picture where you can see the tissue cyst with tracheozoids in them. So this side is the stained one where you can see the stained tissue cyst. So again, the free tracheozoids which are seen either freely or it can be inside the host cells, whichever they are infected. So either inside or freely outside, when you do a peripheral smear, you can identify the presence of the tachyzoids. So this is the oocyst, which is unsporulated. It is from the cat, which is an unsporulated oocyst, which is excreted from the cats. So other than that, using staining methods or directly seeing it, you can also do something called direct fluorescent antibody testing. So you would have studied in immunology where you stain the specific antigen or whatever is required by you by using the specific antibody which is conjugated with a fluorescent. So when they bind to whatever their antigen, they will start glowing. So you can take the conjugated antibodies for the surface antigens of your trophozoites. So once you mix them with any of the specimens you've collected, usually the blood, body fluids, or the tissue, you make a smear of it, mix with that, and you can see the fluorescence if there is infected cells. So this is mostly useful if it's an acute infection, but if it's chronic, they are not easily seen in the smears. So it's better for acute infection diagnosis. Other than that, you can also do immunological diagnosis where you can detect an antibody or an antigen. So for detecting antibodies, you have to detect IgM antibody where you can use IgM capture ELISA method. So IgM is the first antibody to be seen. So you can actually detect the active infection if it's an IgM ELISA. So it takes around 1 to 2 weeks to develop, but useful in cases of congenital infection because IgG gets placentally transferred, whereas IgM is not transferred transplacentally. If you detect IgM in a kid, that means it is a congenital infection. You can also do an IgG antibody detection where you use an IgG ELISA based kit, where in this you have to see after 4 weeks of your infection because it takes time. First is IgM and later on you get your IgG antibody. So leave it for some time. If it's after 4 weeks, you have to check this IgG levels. Usually it undergo peaking by 6 to 8 weeks, after which it declines and it will be usually present in the blood as an as a part of the infection. So when you're checking, you always have to look for the fourfold rise. That means you check at 4th week. Okay, if you get 20, then you check it at 6 weeks. So there should be 30 or 40. So there should be usually minimum fourfold raise. Then only you can say it as an acute febrile toxoplasmosis. So other than that, you also have to look for IgG. Okay, so the classical triad, so the congenital symptoms, the laboratory diagnosis, so DFA or the antibody IgM, IgG detection, or in IgG, there is again something called as IgG avidity test. So in this avidity, it's a more, it's ಮಾಡ್ತೀನಿ ನೋಡಿ ನಂಗೆ ಕಾಣಿಸ್ತಿದೆ ಅಂತ ನೀವೇಂದ್ರಲ್ಲಿ ನೋಡ್ತಾ ಇದ್ದೀರಾ if you're doing an IgG avidity testing, it usually helps to say whether it's a recent infection, because if it's already a memory cell or something like that, the avidity will not be there. So if you do avidity, specifically it says it's a recent infection, and it's very useful during the first 4 months of the pregnancy. If it's positive, it's very good indicator for acute infection. An ELISA method or an enzyme-linked immunofluorescence assay can be done by using your IgG avidity testing. Along with this IgG, IgM, you can also look for IgA and IgE antibodies, where if there is Toxoplasma encephalitis, which is commonly seen in HIV-infected patients, you can detect this. And if it's a congenital infection, which has chorioretinitis, you can detect in them. And even if it's a recently acquired infection also, you can detect IgA and IgE antibodies against the Toxoplasma. So along with that, there is one more test which is called as Sabin-Feldman test, dye test, which is actually not done currently, but however it was done in the olden days, where you take living organism, incubate them with a normal serum. So once you mix the normal serum with the living cells, if the antibodies are there, what will happen? They undergo swollen and they get deeply stained if you add methylene blue to them. Okay, take live organism, put the serum, put methylene blue. If there is antibody in the serum, what will happen? They are going to kill the live organism. So they will become thin, distorted, and they get not stained by the dye. So the dye can enter only if it's a alive cell. So if they get the lysis, there is no entry of the dye. If the membrane is disrupted by the organism, usually because of the presence of complement activation, so the membrane is broken down, resulting in lysis of the organism. So the methylene dye won't enter. If it is not containing any antibodies, then it can enter and results in the cells to swollen up. Okay. So as you can see in the picture, so based on the titer, you can look for the you can give the titers by dilution of the serum, at which half of the organisms are not being killed and the other half has been killed. So based on that, you will give the titer amount. So along with this, you can also use a phase microscopy, where you may not require any staining. You don't add methylene blue, but directly you can see. If it's a phase contrast microscope, directly you can see whether it's a lysed organism or a non-lysed organism when you add your serum. Okay, so that is the phase contrast. If you want to see with the normal microscope, you have to add some dye to make it prominently visible. If it's a live tracheozoids, so next, if it's a live tracheozoids, it's necessary to do this test, and it is very easy to read, and it is highly sensitive, and it detects very less. Other diagnostic methods could be detection of Toxoplasma antigen by ELISA or the molecular diagnosis. You can do animal inoculation by intraperitoneal inoculation into the mice, or do a tissue culture by using murine alveolar or a peripheral macrophage cell lines. You can also have additional radiological guidance by using your CT scan or the MRI scan, where you can detect your Toxoplasma encephalitis. So in the congenital toxoplasmosis, you can do an antenatal diagnosis by doing an ultrasound examination where you look for any congenital lesions, or you can also do an PCR on an amniotic fluid. If it's postnatal, as I told, you can take amniotic fluid, placenta, or the cord leukocytes where you detect your IgM and IgG in the newborn, and along with that, you detect even in the mother. So if the titers is more, then you can think it is a neonatal infection. So usually the treatment, if it's a immunocompetent individuals, there is no much of the treatment required. If it's ocular, you can go with the treatment for 1 month with pyrimethamine and sulfadiazine combined with clindamycin. If it's congenital toxoplasmosis, you can go with daily oral pyrimethamine and sulfadiazine with folic acid for 1 year. If it's an immunocompromised individuals, based on the CD4 count, you can start on with cotrimoxazole, which is the drug of the choice. Prophylaxis can be started once it goes less than 200. You can start giving cotrimoxazole. So prevention is try to cook the meat and then consume. Proper hygiene and proper hand washing is important. Regularly prenatal and antenatally screening to look for any toxoplasma infection in a woman having a childbearing age group, and avoid any cat feces exposure or anything which is contaminated with the cat feces, and screening of blood and blood products for any infection can be done. So the next parasite which I have to talk is the Isospora belli. So it's the same thing as that of your toxoplasma, where there is a oocyst which has sporozoids, sporocyst with 4 sporozoids, and whereas the cyst wall is usually thin and smooth double layered. So here there is ingestion of food and water contaminated with the sporolated oocyst present in the soil. In the small intestine, you will have 6 sporozoids which are released from the oocyst that is going to invade your duodenum and the jejunal epithelium, which gets transferred into trophozoites. These trophozoites will be actively multiplying, resulting in formation of an schizoids, where there is asexual multiplication again to form merozoites. So this merozoites can attack the liver cells, repeating the asexual cycle, or some of them can undergo into sexual cycle, resulting in zygote formation, which has undergone sporulation once it enters into your soil. So you have a mature oocyst which enters, and it is the oocyst will come out in the feces, which undergo maturation in the soil, again, which could be an infective form. So the both sexual and the asexual cycle takes place within the same man based on their immune system. So again, the picture you can see here, the trophozoites which multiplies in the intestinal cell, either they can be in the asexual multiplication or they can shift to sexual multiplication. So again, epidemiologically, they are present worldwide, most commonly seen in tropical and subtropical regions like in South America, Africa, Southeast Asia, even including India. There are a lot of cases that are seen. Humans are only the host which can get infected. There is as such no animal reservoirs, and mostly seen in the AIDS patients. Clinically, if it's an acute infection, you can have fever, abdominal pain, watery, non-bloody diarrhea lasting for a few weeks to months. Usually the disease is less severe when compared to other parasitic infections. But if it's an immunocompromised individual, you can have a severe extra-intestinal infections. Even involvement of biliary tract can happen. So how do you diagnose them in the lab? Stool examination has to be done where you can look for the presence of oocysts. So versus your toxoplasma, you can see here it's an oval oocyst which will be present in the stools, which is usually unsporulated. This is just a saline wet mount. So other than that, the most commonest method is your acid-fast staining. Do an modified Zn staining where you can look for the presence of oocyst which has uniformly acid-fast staining. They are oval shaped with thin, smooth, two-layered cyst wall. Again, the direct microscopy, you can do something with fluorescent staining where you use aurum and rhodoman staining, and then you can observe the fluorescence. Or you can also look for autofluorescence where when you subjected them with an UV light, you can directly see its autofluorescence in a phase contrast microscopy. So other than that, you can also do an duodenal aspiration. Look for the peripheral blood eosinophilia. Molecular methods like your PCR and histopath identification can be done. So you can see in the picture where you can look for the presence of the oocysts. So coming for the treatment, for this also, the cotrimoxazole is a drug of the choice where you can give treatment for around 10 days if it's an intestinal infection. But if it's in cases of HIV patients, you have to use a longer course of treatment. So other than alternative to cotrimoxazole, pyrimethamine combined with folic acid or Cipro can be given. Usually 7 days of suppressive therapy, 3 times weekly has to be given in order to avoid any further relapse. So to summarize, today we covered on two parasites, that is Toxoplasma gondii and Isospora belli. So you studied about the morphology. In the morphology, the trophozoite form, tissue cyst form, and the oocyst form. Whereas in isospore, you have a oocyst and a sporocyst form, which you can identify in the feces of the infected patients. So you learned about the life cycle, what's the pathogenesis, and how they're present. So in toxoplasma, the important presentation is whether it's immunocompetent, immunocompromised, or if it's a pregnant woman. Based on that, the presentation will vary. So whereas in isospora, it is isosporiasis, just the infected host without any other reservoirs you have the infection. So next we learned about how do you diagnose them. So most commonly will be your direct microscopic methods will be very common because culturing methods would be usually very difficult. For isospora, you have to remember it's one of the parasite where you can do a modified Zedin staining method and it's acid fast, which is one of your MCQ question. So it's an acid fast, oocyst it has. And finally, we learned about how to diagnose them and how to treat them. So with this, I'll complete my session.